know if people online can see that. I hope you can. But yeah, do you want to start?
Yeah, so today we'll be talking about an 18-year-old patient we saw on the Wednesday who had hypothyroidism. So we'll give you information bit by bit and we'll ask for your impression at each stage about what you think it could be, okay? So I'm just gonna move this out of the way so you can see. Okay, so just to start off with, so the patient came to the emergency department. She's an 18-year-old Caucasian female. She presented with her mother. She had a 4-week history of constipation, low energy, and nausea. And as well as this, had experienced some reduced appetite and weight loss, according to the mother as well. She's no symptoms of any fever, no vomiting or palpitations, or any kind of recent illness or travel, and denies any respiratory, urinary symptoms as well. And recently, she had been started on 25 micrograms of levothyroxine as she'd been diagnosed with hypothyroidism by her GP. And similarly, her mother also suffers from hypothyroidism as well, and is also on levothyroxine replacement. And just in terms of lifestyle, fairly regular, normal lifestyle. She lives with parents, is currently in school, and doesn't smoke and doesn't drink. So at this stage, does anyone have any idea about, what they think the diagnoses may be before we kind of go deeper to talk about some of the investigations?
How would you guys work up this patient? I know I'm appealing to a room of consultants and residents, but it might be a bit simple, but just get the participation going. So
she seems to be hypothyroid, but then it's not yes, that is why she has lost weight. You'd expect someone to put on weight rather than lost weight.
Yeah,
so
exactly.
So that's kind of like what I'm thinking.
Any other inconsistencies?
Recently, when they say recently started on, do we know what date she started on?
So I think it had been like pretty much 2 weeks of her being on levothyroxine.
So she'd had the symptoms and then she'd started.
Yeah.
So GP did some blood tests, put her on levothyroxine.
And then the symptoms were already there and they're just not.
Yeah, so only
Yeah.
2 weeks.
She's unwell, like a false picture as well, I guess. Also, she's got a thyroiditis.
Yeah, so
kind of complicated picture.
I think the other thing to note is 25 micrograms of levothyroxine. That's a tiny
I
tiny
was wondering
tiny
if that was
dose.
an
It's
age
not
thing
gonna
or
touch.
something.
Absolutely. If she's really got, we haven't got the blood test yet, but if she's really got hypothyroidism, 25 micrograms will do nothing in an 18-year-old. If you really want to treat hypothyroidism, go for a good dose. Unless you're worried that your patient's got ischemic heart disease, angina, then you titrate in, 25, 50, and you build up. But in her, if she's got true hypothyroidism, 25 not going to do anything. So some of the symptoms here may well be under replacement, or it hasn't kicked in yet.
As a bundle figure, you can kind of look at, I think it's like 1.6 micrograms a kilo is roughly what someone's dose should be. So between 1 and 2 micrograms a kilo. So if something significantly higher or significantly lower, that's when you start to think about compliance, true diagnosis, all that kind of stuff. So.
And it's usually started in primary care because, like from this case, the primary care are not very confident like this.
Yeah, with hypothyroidism, they are quite confident to treat, yeah.
They probably also get rego, triage, advice, and discharge.
Yeah.
We probably wouldn't see them.
Okay.
So, moving on. Oops, yeah, Karen, sorry.
Yeah, sorry. In the clinical examination, like go.
They'll come to that.
Okay. So yeah, on general examination, so she was found to be underweight. She's also noticed to have some dry lips, so dehydrated, and she also had low affect and poverty of speech. She had a low temperature as well as a fast heart rate and low blood pressure as well. It isn't mentioned here, but she didn't have any goiter, essentially, no swelling in the neck. Yeah, and normal heart sounds, normal lung sounds, and non-tender abdomen as well. So based on these examination findings, or if you have any idea about if you're trying to elicit any other examination findings, does that change or does it suggest anything that you guys can think about?
Bit worried about her now.
I think underweight is an understatement here. She had a BMI probably of 16,
Yeah.
17.
I don't think, did we actually get a BMI in the end? Because I don't think she was weighed.
Was she never weighed?
No, so I don't think she was ever weighed. So as things go in
I think there was a
ED.
documented weight actually.
Okay.
But she looked very,
Very
slim,
skinny.
very,
Yeah.
So BMI really is 16.
Yeah, as of now, we don't know her BMI. Yeah.
You almost worry that she's been thyrotoxic, which
Yeah.
is rate and ADI.
Yeah. I guess the other thing to mention here is her BP is 87 or 64, but we don't know if that's her baseline and if whether that's something that's an acute change. She did say that she was quite tired, but nothing of the sort where she's finding it difficult to get out of bed or having a postural drop or anything on those lines. I think it was more just generalized tiredness. So maybe that helps put the BP into picture a little bit more. But yeah, any other thoughts from anyone?
What do people think about the low effect and poverty of sleep? And most of the history was given by the mom. She was barely just no and yes.
Just like thinking about anorexia nervosa.
I think that was that crossed our mind, yeah, absolutely.
Sure. Okay. So the initial impression and plan from the people in the emergency department was that this may be some uncontrolled hypothyroidism. And the initial plan, at least, was to chase some blood results, do some bloods, CBG, do a urine dip, and give her some food, essentially.
Is there anything people would do differently, just on an initial clerking while in ED with that history?
Or what bloods would you like to see? Like what bloods would you specifically order for this kind of patient?
She's pale, so I would do a full blood count.
Yeah.
And then I would do the thyroid function, but I would do thyroid antibodies as well.
Any other
And
blood tests?
yes, or CRP to see if you can have some future information going on in the thyroid elsewhere.
Yeah.
Do you have any vomiting? So maybe she could give her a bit of fluid if she dehydrated.
So she's had one, so we'll get to it. She's been nauseous, she hasn't vomited yet.
I mean, I'm pregnancy hydration, I think, not
Yeah,
being on
pregnancy,
heart rate
yes.
120 and a blood pressure of 87, even if she's young and otherwise being quite bold.
Yeah,
I
so.
think he was a bit bold. Tell us that.
Yeah, so definitely, I think whacking some fluids on is probably also a good idea at this stage. But
So they done venous blood gas as well, just to get an idea of electrolytes.
we can share that with
Did they
you.
do one when she came in? They did it.
Not-
They
not
sent
when she
blood,
came in.
So it was kind of slow process, routine bloods.
Move in ED as well towards kind of rationalizing doing BPGs as well. So as opposed to say, you know, if you want to check a lactate, you should send a lab lactate. You should, so it's kind of like using it sparingly. And there is definitely a discrepancy as well, isn't there, in BPGs, and we have a lot of patients who are under treated or over treated for their sodium based on BPG samples as well.
So on the initial investigations on the bloods, these were like some of the most, I guess, important findings of note. So there being very low iron, low sodium, low chloride, high liver enzymes, and normal creatinine, EGFR, so normal kidney function there, and high TSH with the low T4 as well. And then, yeah, the hepatitis and HIV screen was negative.
So you mentioned ESR, CRP, they weren't really elevated. If it's not on here, you can ask me, and it was probably normal, but I can let you know if it was done or not.
Glucose as well, I think.
Yeah, so the BBG is coming around. Her glucose was, I think, 3.8, slightly on the lower side, but nothing glaringly concerning. Just to take you through the BBG results, so the only thing really that stands out there is that she's got a slightly low glucose. Anything else that was on there? She hasn't really got an acidosis or alkalosis of any kind. And she's got a low sodium of 114 on the BBG.
Does she have any background of autoimmune disease? Iron deficiency anemia ever explored?
So she does, so her mother does have iron deficiency anemia as well. And in terms of autoimmune disease, she was like screened with questions like does she have any like family history of like vitiligo or any other kind of autoimmune? And that was negative.
Her mum has hypothyroidism as well.
Yeah.
So at this stage, has anyone sort of changed their differential or
You want to add a differential?
reinforced
Yeah.
what they were thinking before?
So that was the bloods that pushed for referral to us.
Yes.
Yeah.
Okay, so only when the blood came back, that sort of triggered a referral to us.
Was the urea normal? There's not.
The urea was normal. Are we concerned about this patient?
We've got mixed edema. Picture now, she's quite profoundly hypothyroid.
Okay.
With a low effect and paucity of speech.
Hmm.
Or if she's like mixed edema coma.
Yeah.
But she was still tachycardic, which I can't really explain.
So the lab potassium was okay.
What was it exactly? It was 4.6, 4.7?
Yeah, maybe on the high normal side, I
High
think.
normal.
So biochemically, like the TSH, she is hypothyroid, but clinically she looks hypothyroid. So I think it's like a thyroiditis, or is this more than one pathology maybe?
Is there anything about heart involved, cardiac involvement, secondary, like profound anemia?
No, so no
No.
history of chest pain or palpitations, nothing like that, which indicates on the patient and their exam was also completely normal.
Not overloaded, yeah.
Yeah.
No.
If anything, she's dehydrated.
Yeah.
So
Dry lips. Yeah.
She was very good.
yeah.
And sinus rhythm?
Yeah, sinus rhythm. I don't know. There's one blood result which I feel like is concerning to me, which we haven't really talked about. What do people think about the sodium?
Hypernatremia screen.
Is that, would people be reassured? Because one of the cause of hyponatremia is there.
Yeah.
Okay? Would people actually just say, oh, well, we've got our diagnosis, clear cut, let's treat that and it will get better? Do people feel comfortable? I suppose ED was sort of thinking
Yeah,
along those lines
definitely.
when they referred. And if there was 25 of microgram of paroxysm is not enough, that needs to be bumped up and the sodium will get better because hypothyroidism is a cause of hyponatremia.
Yeah.
But do you feel comfortable with those? I know we're smiling, but do you feel comfortable with that?
It's very low, but I don't know how low you go with them in that sort of age range.
Have
where you can
people
compensate.
seen, actually, have you ever seen like hypothyroidism cause that severe hyponatremia? Surely,
Something in the chat, people are
Oh, yeah.
watching.
Oh, well, let's have a look.
so I haven't seen it. Have you seen Manish?
No, I think it's even outside of the context of being an endocrinologist. I mean, even in GI, to see on acute, you don't
Yeah,
really,
you don't see.
you ask for it as a
You ask.
hyponatremia screen, but you very
Yeah.
rarely expect it to be the true
Yeah,
pathology.
I think 130 rather than
Yeah.
120.
And just looking at the thyroid function, I think often we're deceived by the TSH being
Yeah.
very, very high. It's just someone mounting a very good response to being underactive. It doesn't necessarily, sometimes you might see a TSH more than 100. That doesn't necessarily mean they're more hypothyroid than someone whose TSH is 60.
Absolutely, because
Just
if
the
you look at the T4, it's actually the normal, isn't it?
Yeah.
Okay, it's not that low, it's not undetectable.
And if she were very severely hypothyroid,
Yes.
clinically, she's opposite of what you would
Opposite,
expect.
absolutely, absolutely, and they get edema, they'll have
Exactly,
positive
exactly.
sign as well,
Yeah.
which we don't really see in
Bradycardic,
UK.
So we mentioned the anorexia angle. Do we think like anything from here maybe
Somebody
supports
said
that?
very
Or?
severe hypernutrition, a young person,
Yeah.
severe hypernutrition.
Mm.
Absolutely, I agree.
Thank you, Zoom user. But yeah, anyone want to forward on the anorexia angle of things?
What about the eating disorder that somebody mentioned? Could that be fitting here with some of the?
Low bicarbonate, low potassium, maybe
Mhm.
that's it.
Yeah,
Mm.
absolutely, that is it, I think that doesn't fit, the potassium was high normal.
Or if there's a degree of like bulimia or vomiting. And then lots of sodium and dehydration as well.
Is there any other causes of low sodium where people would be a bit concerned about in terms of, like I said?
So someone mentioned hyponatremia workup. Anything that we're trying to screen for specifically?
Like Addison's,
Yeah,
no, your
yeah.
potassium is the upper limit of normal.
Yeah.
Yeah, okay.
Okay, cool. So go to the next slide. So after being seen on the medical,
You might want to get rid of.
yeah, after being seen on the medical take by the F1, so IV fluids were started and the urine sample was taken as well. And just, as I said, more information from the F1 took. So there was no chest pain, no abdominal pain, no kind of muscle cramps. So the kind of the hyponatremia wasn't giving any kind of like neurological symptoms. Furthermore, it's found that she did suffer from anxiety and also takes propranolol to help treat that. On further like closer examination, her skin looked slightly yellow and also had some teeth discoloration. And she had recovered from a viral flu around 1 week ago. And furthermore, sorry. Again, these are just looking at her. Observations again were retaken, still a bit low, still tachycardic, and blood pressure was still a bit low as well. And furthermore, she also noticed there was some slight bronze pigmentation in the skin folds in the hand as well, and little wheeze as well in her chest. So based on this, does this support a certain diagnosis? Does it make you change your thinking about anything? Or like, what would you like to do at this stage?
I think the bronze pigmentation, isn't it?
I wasn't convinced about that.
Yeah, so-
Were you convinced? Did you look
Well,
at her?
Yeah,
Were
I
you
did.
convinced? I don't know. I
No,
wasn't convinced by
100%,
that.
no,
Maybe the
100%.
jaundice then was.
But the jaundice was not jaundice. I think she looked
Yeah.
Just looked a bit, yeah,
very
it's
off
okay.
color. Off color.
Yeah.
Not right.
She didn't look right.
The other thing I think we wanted to point out that you mentioned to us, bronze hyperpigmentation is not necessarily an Addison's feature. I mean, just to the floor, what condition would you expect bronze hyperpigmentation is?
Hemochromatosis.
Yeah, exactly. And we're not really concerned about hemochromatosis in this patient. So it's just like to point out that the way you call things kind of does matter sometimes. But yeah, so are we sort of happy with the Addison's picture? Anything we've mentioned, I think hypothyroidism, eating disorder, and maybe an adrenal crisis as are potential things that we're trying to consider in this situation. Anyone want to give us some reasoning why, yes or no, based on the additional information that we have?
There's something about giving thyroxine, or ended up masking a sense of something, or the other way around. I'm not sure.
I think it's the other way around. If somebody's got Addison's,
Yeah.
then you
It's
give them
thyroid.
levothyroxine. It may, that's theoretically,
Okay.
basically to precipitate the crisis. Because you're increasing the metabolism, aren't you?
But
But
in
25 will not be
this
much.
case, it's too small. Yeah.
I think that brought up last week at the teaching session was about propranolol as well, and how awful beta blockade tends to make people feel as well. So if you already have slight hypotension, fair enough, she's tachycardic, and then you start doing propranolol on top of that.
Yeah.
So feeling a bit sick, feeling a bit tired, feeling a bit lethargic, if your blood pressure's falling a bit further, a bit you're kind of suppressing your heart rate as well, maybe that can be a contributing factor.
So are we allowed to ask? We can't do a random cortisol. This is not
Yes,
helpful.
that's it.
Good suggestion.
That's a good suggestion, indeed.
It's the first test.
It's gonna
Okay,
take a long time to come back, actually. Came within an hour. Anyway, yeah.
yeah, so so afterwards, some differential, I think the F1 had some differential diagnoses as to what he thought it could be. So potentially hypothyroidism, anorexia, pituitary dysfunction. And I think after conversation with the consultant on the wards, an adrenal insufficiency workup was also added as part of the plan, essentially to obviously reduce the risk of something like an Addisonian crisis occurring in this patient. So yeah, we checked for the cortisol essentially. Yeah. Okay.
So before we reveal the results, we're just going to go through reasons for and against each of these. I don't know if the crowd wants to chime in. So what do you think supports or goes against that diagnosis of anorexia in this patient?
Tachycardia goes against probably.
Yeah,
I mean,
you could have either way. Yeah.
Direction, so on, yeah.
I think the potassium would be
Potassium,
lower.
Yeah.
I agree.
She didn't have a prior history as well.
Yeah, so nothing on talking to the patient. I mean, she did have a low affect. She was taking propranolol for anxiety, so maybe you are thinking there might be some sort of mental health angle to this, but not enough for it to be chronic enough, I think, to really result in the biochemical abnormalities that we're seeing on this admission.
Even the anorexic patient that I know could get hyponatremia, they drink a lot and a lot of water because they don't want to eat, but they want to have low calories, so fill themselves with lots of water, and that can lead to hyponatremia without the low potassium. That's the only case I can think of, but the majority will have hyponatremia.
Yeah, cool. So some things that we thought of were supporting would be the low effect, weight loss, poor appetite. You can get a low T4 in eating disorders. And then, like we mentioned just now, low sodium either because of dilutional hypernatremia or because of excessive laxative use, but you expect a higher potassium in that case. You can also get deranged LFTs in anorexia, so that was something that we saw in this patient. And then, you know, the history didn't really indicate that that was more of a consideration. They had a high TSH, which is not typically a finding within patients with eating disorders. And the hyperpigmentation doesn't necessarily fit in with this. Hypothyroidism related to hyponatremia, any for or against?
Very rare, I like them.
Yeah, so quite a rare thing. I mean, she did have a high TSH and low T4. She was being under supplemented, if you will, but I think this patient wasn't really giving signs of a mixed edema coma, and it just wasn't the right clinical picture. So, and then adrenal insufficiency. So reasons for and against.
Electrolytes fit in, don't they?
Yeah. Yep.
Blood sugar.
Yep.
Low blood pressure.
Yep. So quite a good one to have. And then the only thing that maybe would go against is the fact that she had a normal potassium, but again, it's like high normal. So in that case, maybe you're okay. SIDH was another thing to consider. This is something we've taught in med school a lot, but why would you not consider SIDH in this patient yet?
You have to have normal thyroid function now and adrenal function.
Yeah, so diagnosis of exclusion, you need everything else to be normal. So we should have done TFTs and the cortisol before establishing a diagnosis of SIDH, essentially. But you can still get the hyponatremia. You can still get SIDH in people that are a little bit fluid deplete, but it just doesn't fit the picture as nicely. And then autoimmune polyglandular syndrome. So maybe this is a case of both thyroid and Addison's, which is what sort of we're working up towards anyway. And then final reveal, the cortisol was 28, undetectable. So yeah, this was just an opportunity for us to talk about, I guess, Addison's in a patient that wasn't, I guess, the thyroid aspect of things really took a step away from considering adrenal crisis at first. And it's just to say that if you have somebody come in with hyponatremia, especially, definitely work them up for Addison's as well. I thought it would be just to complete the patient journey, based on the hyponatremia and cortisol levels, we established diagnosis of adrenal insufficiency. She was given IV hydrocort. I think she's now discharged. Yeah, so she recovered well with the IV hydrocort, no issues overnight, and then the day after she was given steroid advice and steroid card, and now she's well outside hospital.
But she's got two pathologies there.
Yeah.
That one was kind of
Masking it. Yeah.
So before you move on, do we just go back to with the cortisol? So you often ask for a cortisol. What's important to consider when you look at that cortisol?
Did they have hydrocortisone before?
Okay, so if they'd had hydrocortisone, what would that cortisol be? So hydrocortisone is picked up on the assay. So you'll actually get a really high reading. So if you've already hit them with hydrocortisone, just because you're worried they're hypotensive, you're concerned that they're Addisonian, and you haven't sent the cortisol off, you'll get a reassuringly normal or high cortisol because you've already given them a slug of hydrocortisone. It's also useful when we're seeing patients admitted is looking at the LAS sheet as well, because sometimes they would have had a slug of hydrocortisone with LAS. So when you do a cortisol, then it may actually come back reassuringly normal as well, which is why just a quick scan of the LAS sheet is also quite useful. What the other consideration? Other steroids?
That wouldn't be picked up.
NETs wouldn't be picked up on the assay, high dose prednisolone wouldn't be picked up on the assay. I've seen 1 or 2 patients who've actually have been given prednisolone by LAS, or the GP has recently started for an unrelated pathology, because you had parents salbutamol on your plan as well. I don't know if she was a bit wheezy or.
Yeah, she was just a bit wheezy. I'm sorry.
So she could have had, been given some steroids in the community as well. She's had, 30 of pred for a couple of days. That would explain that cortisol as well. So it's always useful, you always get that as a med rage at the other end of the phone. It's like cortisol is undetectable from clinic. Bye. And put the phone down.
There's a question there.
Oh, has someone got their hand up?
Yeah, I do, from St Mary's. I was just going to say the ACTH would be really helpful in that case.
So I was going to come to that. So I guess what I want to say.
Sorry, just one last other thing.
Yes.
I was going to say, just with the newly diagnosed hypothyroidism, I'd have probably stopped the thyroxine in that context too.
Yeah, I guess, yeah, you got the point. I guess we start on treatment, so I wasn't worried. So we gave her the hydrocortisone, and then she's going to have the levothyroxine 75 the next day. So I wasn't too worried that this would trigger a crisis. But yeah, good point. So that's the point that you were making, Brendan. So I suppose this is the case where a random cortisol is very helpful. Random cortisol otherwise is not helpful at all. But here we're suspecting Addison's in someone who's coming really unwell. A random cortisol is so useful. Otherwise you have to do it in the morning. Okay, you have to wait. So your normal, typical hyponatremia patient that comes in, not very unwell, there's no point doing a random cortisol. So you wait for the morning. But here, you expected that to be super high, it's kind of detectable. And at the same time, we send an ACTH, which one of you did on ice, hopefully. And we're still awaiting that, and that will clinch the diagnosis, essentially.
Sorry, I have a question about the BBG. I think the acid-base balance doesn't really fit with Addison's, does it?
Not really.
Like it was a low bicarb with low PCO2 and so normal pH. It almost
you'd
the
expect-
potassium was not,
and it was
elevated.
not high at all.
It wasn't. So I suppose she's probably, the reason why she wasn't well, but she wasn't in crisis, I would say. I think her blood pressure was low, but maybe her blood pressure always been quite low. And she wasn't yet hitting that crisis. Maybe there's still a little bit of mineralocorticoid floating around. Maybe there has been some sickness, some vomiting, which actually lowered her potassium, possibly. So that's maybe why we're not seeing that. But I don't think she was in full crisis.
And did we send off a renin for her to see? I think it was in the list, wasn't it, of the.
Yeah, it was on the list.
Again, it takes weeks to come back.
Yeah, it's not something I saw on Serena when I was looking through the results, so.
So renin's useful to look at your mineralocorticoid activity as well. So if you actually have a decent renin, then you might not. I mean, we don't do a practice, do we? You start on fluid.
Yeah, she's been started on fluid.
Yeah. Cool. Any other questions? Yeah, so we just to hammer home, you do a synaptic intervention for this patient, and it's important as well to do thyroid antibodies just to confirm that this is autoimmune hypothyroidism. I didn't really see serum urine osmolarities on her Serena results, but I think that's also an important part of working up this patient. This was on there, but I wasn't really sure about the CT abdomen for adrenal imaging, if Addison's is suspected. I suspect that's not a routine thing that's done, but I don't know if you guys want to weigh in.
No, I guess here, she's a young girl. She's got family history. She's got thyroid. It has to be autoimmune.
Yeah.
So you can send antibodies. You don't really need to do a CT. It's part of the guidelines, but you don't necessarily need to do it. Even the TPO antibodies, what is that going to help you with? I mean, she needs levothyroxine, so we wouldn't do it. But yeah, it's part of the guidelines.
I think something that Brendan, I think you mentioned earlier about the antibodies.
Yeah.
So from the thyroid point of view, the only really useful antibodies are the TSH receptor antibodies for hyperthyroidism, because you often get a lot of referrals for a TPO of more than 20,000 or something ridiculous. And all it means is that they've got a propensity to develop hypothyroidism at some point. And all it triggers is maybe more frequent monitoring of their thyroid function tests. But the result in itself doesn't necessarily confirm or refute a diagnosis of thyroid disorder. It would feed into the kind of autoimmune element of this as well. But that's the only thing it would kind of increase your suspicion if it came back positive.
And with Hashimoto's, you would get kind of a high free T4, wouldn't you?
Yeah.
I guess the gland is just released it. And you would
Yeah,
get a low
and
TSH,
eventually
I guess. Right.
from it, yeah.
Cool. Just a recap of some basic medicine. Hyponatremia, when you're working them up, check their volume status, check their plasma and urine osmolalities, and check their urinary sodium to try and classify it. If they're hypovolemic, then and the sodium loss is renal, then you're considering diuretics, renal failure, Addison's, or mineralocorticoid deficiency, or even hypothyroidism. And then if the sodium loss is not renal, it's probably because of vomiting, diarrhea, third space loss, burns. If they're hypervolemic, that's, I feel like, an easier one to tackle, but congestive cardiac failure, liver failure, and nephrotic syndrome, you'd fluid restrict. Euvolemic, then here's where we're getting into SIADH. If you've got a high urine osmolality, or if it's normal, maybe psychogenic polydipsia, or even severe hypothyroidism.
I think Mary's had their hand up. They want to.
Yes, hello, Mary's.
I I mean, no one likes the urinary sodium more than me, but I think if you've got the diagnosis of Addison's, I probably wouldn't order it personally. And the only other thing I was going to say, and I think a really important step in management, I'm sure you did this, is when you discharge the patient, warning them about sick day rules. I think generally actually we're not great at doing that. And trying to tell them to get a steroid card on discharge, because occasionally we do get a few disasters because of that.
You saw her, you tick all those boxes, didn't you?
All done.
Yeah, so this was banned for this patient. And then quickly, in terms of why hypothyroidism can result in hyponatremia, essentially through different mechanisms, you're either getting an increased ADH or you're getting water retention. So either you're having decreased cardiac output or losing nephropathy. I guess that's more consistent with something like Addison's as well in the picture. I just thought it was interesting to put the slide up there. I'm going to let you look through it for a second. I don't want to read off the slide.
So I think Dr. Farag made a good point about the test that he quite likes. And actually, of all the hyponatremia screen tests, the urine sodium is probably the most informative and the most useful. So if you think about the serum osmolality, in any case of true hyponatremia, your serum osmolality will be low. Yeah. It will only be useful if it's something else like protein, paraprotein, lipids, glucose, something like that. It's a pseudo hyponatremia. So if you're convinced it's a true hyponatremia, then actually it will just be low. So waiting for the serum osmo won't help you guide your management necessarily. Same with urine osmo, because the range is so wide. It can tell you whether the urine is dilute or concentrated. It's useful in the context of something like diabetes insipidus, where your urine is very dilute. But otherwise, if it's 300 versus if it's 600, it doesn't really necessarily steer you. So the urine sodium is the thing that helps guide you about whether it's renal sodium loss, if it's more SIADH, or is this all hypovolemia? So the urine sodium is the one test which is really important to send off.
But make sure you exclude cortisol deficiency
before you send it off.
Anything else. The picture will be the same as the IDH. Cortisol deficiency in Addison's give you exactly the same urine sodium, urine osmolarity, plasma osmolarity, exactly the same picture as the IDH. So make sure you exclude that.
And in terms of doing the SST, I think everyone thinks you have to wait till the next morning to do the SST. It's more, you can also look at the increment of the raw values. So you can do it at another time. If you're really highly suspicious and it's in the afternoon and you can't spare someone at 8 o'clock in the morning to do it, you can do it a bit later as long as they have the right increments.
Presumably, if it's so diagnostic like this one, the urine.
For this one, you probably don't need to because the clinical picture fits the cortisol level undetectable. You could, for academic reasons, good for completion, say, do it, but you probably don't need to.
And then the only other thing I thought I'd mention is some of the physical and biochemical findings you can get in anorexia, because I think that's not something that's very well known. But physical findings, I think we're a bit more comfortable with: weight loss, fatigue, dizziness. The other thing to think about is hair thinning or a dry skin. And then on the endocrine side of things, you'd expect irregular absent menstrual periods for this patient. On the endocrine side of things, in the biochemical aspect, you can get hypothyroidism, you can get hypercorticolism and hypogonadism. And then other things that you can see, you might see a low potassium or a high potassium with high laxative use. You can see a low sodium if they're diluting themselves or using laxatives. You would expect a metabolic alkalosis if they were, for example, vomiting a lot. And then you can get deranged LFTs as well. So just thought it's worth mentioning that. Anyone want to add anything there?
So for this lady, if we said she's not got anorexia, why was she so iron deficient? Because the ferritin was really low.
So I think there's also a family history of iron deficiency anemia for her. So maybe that's something that for the GP to consider and work up, because she yeah.
Absolutely, we'll
Might be
really do
12
into that.
folate or done.
yeah.
It would be
So
12 folate
I don't think they were done on this admission.
NACV or
We just look at the acute picture,
Yeah.
and then in clinic, we'll do all the rest on the screen, you know, your type 1 diabetes, the rest of the celiac and so on. So
Yeah.
we'll look into that.
For sure.
St. Mary's. Background.
Yeah.
Yeah, I was going to say, that's a really good summary of the findings in anorexia nervosa. I think what's really important to emphasize is the albumin in patients with anorexia is normal. So if they have a low albumin, you should look for an alternative course for it. So that's a really good point.
Thank you.
The one thing I found very interesting looking at this patient, the teeth.
Yeah.
The teeth were discolored, yellowish brown. I don't know whether that's got something to do with Addison's. I've never come across that, but they were definitely very abnormal one day.
Yeah.
That's the only thing. Did you look into the literature? Is there something
No.
to do with Addison's? I found that really interesting.
She's sure she's not bulimic.
She said she did.
Guys, come on. Somebody ask the
Maybe
question.
she's got dual diagnosis. Maybe who knows? We'll find out a bit more. But that was
Yeah.
really interesting. Her teeth was not normal.
Yeah.
I think from an Addison's and a kind of adrenal insufficiency point of view, there is a more of a shift, particularly here, to put people on prednisolone. So don't be deceived by the fact that someone's on 3 to 5 milligrams of prednisolone instead of the typical hydrocortisone 3 times a day. So I think it's just to be mindful that some people are on just the once a day, particularly ones with secondary adrenal insufficiency, not necessarily Addison's, may just be on a little bit of pred. And then the sick day rules, I think we technically still apply to there. But I don't know, I can cap it off as 15 and then not try to give more sick day rules above, you know. If they're, for example, if they're on, as in, when you're doubling the dose.
Oh, my cap is 10.
10, there you go.
And that's important because we saw some patients who came on 10 milligrams of prednisolone and basically would double it to 20. There's no need to double to 20. 10 is more than enough. It's a super physiological dose, so you don't need to double up.
And also checking your cortisol. You can check a 9 AM cortisol while someone's on prednisolone, but ideally they need to be on 3 milligrams or less than 5 milligrams for it to be interpretable. Anything higher than 5 and it will be suppressed. Some people say anything higher than 3 and it will be suppressed. But you can do it. So if they have 3 milligrams on one morning, you can check it before their next dose next morning. I think we also have a prednisolone assay. You can check out like 6 to 8 hours. You can check a prednisolone level, make sure adequately. But that's why there's a bit more of a push for people, especially managed imperial, will actually be on prednisolone rather than hydrocortisone.
Yeah, that's pretty much the end of it. I think it's just more to the main take-home message, I guess, is when you have somebody come in with hyponatremia, make sure to work them up for both the thyroid and adrenal insufficiency side of things before considering other diagnoses, as is in this patient. I think that.
Excellent, thank you very much. Very good presentation.